Welcome to Let's Talk About Health, an informational podcast that gives you insights on health and fitness from experts themselves that you can apply directly to your own personal health and fitness stories. Come join me today to hear all about what they have to say on health and fitness. So, welcome to Let's Talk About Health. Thank you so much for being a part of this talk show and coming forward and just talking about health and fitness. I really appreciate that you have so much of surgical and orthopedic background and you're willing to share that knowledge with everyone. And I know that you like teaching. This is also kind of teaching. And so I want to take a minute and just appreciate that and thank you for those efforts. Thank you, sir.
Of course. It's my pleasure.
Okay. So let me start by asking you my favorite question.
Yeah.
What is health?
God, it's a great question. Especially nowadays, it can mean so many different things. I think through my life and my medical training, mental and physical health are probably the two biggest things I think of when I think of health in general, and that being taking good care of yourself. You know, you've only got one body for your whole life, and so taking care of it physically is important with diet, with exercise, making sure you're staying proactive in your health. A lot of research nowadays is going into preventative medicine and not so much reactive medicine. I know when I was growing up, a lot of it was reactive. You started to feel bad, you waited a few months, you finally saw your doctor, and the doctor would react. And now medicine is really pioneering preventative medicine. Things that can we target things before they become a significant health issue in our patients, and even start intervening before these conditions become severe and life-changing. Physical health with exercise, I mean, through our lives, exercise has become more and more and more important. And even through the advances in medicine with prescriptions, with surgical techniques, every single physician will still tell you good cardiovascular exercise is one of the best things you could do for yourself. Sure, we've got medicines for everything, medicines that can slow cancer, medicines and research that are helping us help reverse Alzheimer's. But all in all, maintaining a good exercise regimen throughout your life is important for long-term health. And then nowadays, mental health has become at the forefront of our news media, at the forefront of even me as a surgeon. When I first started training, I really didn't think, as I chose a surgical subspecialty like orthopedics, that mental health would play such a role
Right.
in how I manage patient care. And there's great research that comes out every day that shows that mental health is just as important when treating a patient, whether it's with surgery or not, and how this can affect outcomes. Even if you're not treating the patient for their mental health concerns, it can play a role in how they recover from an orthopedic surgery. And then maintaining your own health. You know, when you're taking care of patients, it is so easy to let your personal health as a provider go by the wayside. And it just builds up, you know, in your mind. You're like, I have to take care of these patients. These patients are relying on me. I've got emails to return, patient questions to return. I've got an inbox full of stuff. And if you don't take a moment and make sure that you're maintaining your own mental health to prevent burnout, it can take quite a toll. So when I think about health, those are the two biggest things I think about.
Right. You mentioned mental health. Since I've been practicing, I'm observing that in physical therapy too. My patients, they're doing amazing physical training. We're doing so much of strength and conditioning. But then all of a sudden, out of nowhere, they're just lacking in something. It's just soreness or it's just uh, a back step. And I'm wondering, we're stretching, we're working on strength, we're doing every possible thing. Why is it coming? And then I sit down and I talk to my patient, and then she tells me, I don't feel like myself. I'm depressed.
Yeah.
And then I took that in consideration and I started asking her what she wants to do, what gives her pleasure, what work. So she said, like, for example, gardening or going out dancing. So I prepared my protocol according to her. We got a garden kit and I made her do gardening, just the
Yeah.
toys. We prepared a whole exercise, and after that I noticed there was tremendous change within 3 to 5 sessions. And mental health, we give it so much less credit, but it plays such a huge role.
No, absolutely. And I love implementing the things that people like to do in their recovery as well. I think that's super important, especially in orthopedics when you're doing a lot of quality of life medicine. These patients are already coming to you because something in their quality of life's wrong. And a lot of times it's, yeah, especially here in Texas, it's like, hey, doc, I can't golf anymore. Like every time I play pickleball, like something hurts and it's affecting their quality of life. And a lot of times if you do a surgery, they can't go right back to it. And so they weren't able to do the things they like to do. And there is some recovery on the back end, whether it's through therapy or through surgery, and they can't and don't go right back to
Right.
what they were doing or enjoying quickly, like they were before they got injured. And maintaining, I think number one is expectations. I always try, and I'm not perfect, but for sure try and fit in at least at some point in our conversation managing expectations, because when you're dealing with somebody who either has a history of mental health or is just feeling bad because they can't do the things they like to do, managing expectations, setting out a timeline, and then reassurance. Patients think, oh, yeah, and we talked about this before we came online, that a lot of the surgeries I do as an upper extremity surgeon take less than 2 hours. And so in a patient's mind, it's like, well, shoot, the doctor, he was only in there for 2 hours. How come I'm 8 weeks, 12 weeks out from my surgery?
Yeah.
And I'm still not quite back to normal, but they're doing a good job. I'll see patients in that middle where they're about 8 weeks out from their surgery, and they're like you said, they come in and something's changed. They were optimistic, they were motivated, and they come in, and I'm like, hey, so what's going on? And then they'll, like you said, as long as you ask them, they'll open up and talk about, hey, I thought I'd be further along than I am, or I feel like my progress the first few weeks were so quick, and now it's just so slow. And it's, when you get that quick feedback, that positive reinforcement, I did A, I got B, and it was quick. And then later on in therapy, going from B to C can take a little bit longer. And just even providing the patient, like, hey, look at this. Look at where you were a month ago. Think about where you were a month ago. Look at how well you're doing now. And think about that we're not making any steps in the wrong direction. They're just smaller steps in the right direction. And just having that quick 2 to 5 minute conversation with the patient can make all the difference. Remotivate them, dedicate. You know what? You're right. Like I'm a little upset that I'm not golfing yet. I'm a little upset that I can't lift my grandchild yet. But providing that reassurance for somebody who's either dealing with preoperative mental health or just kind of dealing with it in the acute phase can really, really help a patient's outcomes.
Yeah, therapists have to be, for that matter, I think everyone who's in healthcare have to be motivators. They have to keep pushing, and like you mentioned, functional is the next step. It's coming up. You have to be more functional based. Your exercises, your protocols, everything has to be more functional based, and that has to be patient specific, I believe, more than anything. Can you tell me what made you decide that orthopedics and especially upper arm, upper extremity is
Yeah.
your field?
Yeah, absolutely. So when I first got into medicine, I thought I wanted to be a hematology oncologist. I had a blood disorder. I still have it, but back when I was a kid, I had a blood disorder, and I was in hematology offices weekly for a few years, and so knew very early that I liked science. And then as I got through undergraduate studies, I knew I wanted to be a physician, and then right before I started medical school, I met a couple of very influential orthopedic surgeons that are still my mentors today. And they let me shadow them. And I realized, that being an orthopedic surgeon is very gratifying. These patients come in most of the time with a problem that you can fix, whether it's surgically or not. And went through medical school, did some research in orthopedic surgery, kept shadowing, kept doing rotations in orthopedics. And I just found that my personality fit with the personality of orthopedic surgeons quite well. I did like that gratification when eventually most of our patients do quite well.
Correct.
And then I initially really had a passion for spine surgery. So most of my research through medical school was in spine surgery with one of those early mentors, and realized that I did a rotation in February. I remember it in February, my intern year, and then went into upper extremity the very following month. And I think the fact that upper extremity surgeons can be fracture surgeons, sports surgeons, tendon surgeons, nerve surgeons, artery surgeons. I can do flaps, I can do nerve transfers, I can fix fractures, I can do shoulder
Right.
replacements. I think the fact that that field led me to do all of that stuff um, was, I think, the biggest reason why I stuck with upper extremity surgery. In a certain operating day, I mean, just a few weeks ago, I did a shoulder replacement, a carpal tunnel release, a tennis elbow debridement, an elbow arthroscopy, a wrist arthroscopy, a trigger finger, and two finger fractures. And that to me is the best day.
Right.
Is when you could do the whole thing from shoulder down to fingertip, and know that you're doing a good job.
I can relate. That's the reason why I chose orthopedic physical therapy, because it gives you satisfaction of like getting results quick. And I somewhere deep down I like that. I'm not saying I have huge respect for neuro and cardio, but it takes so much of patience and it takes a lot of motivation, not just for the patients, for the doctors, for the therapists. Ortho is very simple, I would say.
I would say that as well. I think that I often think I'm like a golden retriever, and so when patients come in and they're happy and they're excited and they're pleased with their outcome, it makes me happy and excited. And at the
Right.
same time, I'm very emotionally invested in my patients, and I found that one of the things about hematology oncology, I mean, bless those individuals who can do that, because the highs are really, really high, but the lows can be so low. And I felt like I even in the few poor outcomes that come from orthopedic surgery, because like we talked about, mostly positive outcomes, it kills me. I'm like, I think about it. I wake up in the middle of the night at 2 a.m. and I think about it. And I think if I had gone into a field where I knew I could be successful, like hematology, I felt like my personality was much more geared to the field of orthopedic surgery.
Right. Yeah, it's very scary. Like I take it personally. I'm a person who gets personally invested. And if someone, you can feel, you have to feel their pain. Otherwise, you have no business being a healthcare, being in that industry. If you cannot relate to their pain or if you cannot feel.
Absolutely.
Yeah. Why arms and upper extremity?
Yeah, so I played baseball all the way through undergraduate school, and had, as most orthopedic surgeons do, they've got some kind of injury that sparks their interest. I think once I started to get treatment for my personal conditions, and learning how, I had an elbow injury, but how my shoulder and how it was functioning when I was throwing was affecting my elbow, and how the upper extremity is such an intricate balance between very complex joints. The shoulder joint is a very shallow ball and socket joint that relies a lot on ligamentous and tendon stability and integrity for its function. The elbow is a joint where three bones meet at the distal humerus and have dynamic and static stabilizers. And then down in the wrist, you have the two bones of the forearm meet the carpus, and the intricacies of the intercarpal ligaments and how that plays into. And I think the complexity of the upper extremity really motivated me. I found that things that were a little bit more easy, or a little simpler to grasp, it was easy to learn, but it wasn't interesting to treat. And then in just the wrist, there's so many different things to think about. Even when a patient just says, "Hey, I've got pain here," there's like automatically like six things that are in my mind that can cause pain there. And that, I think, the complexity of it and the challenge that I get when I treat these patients is why I chose upper extremity surgery.
Would you recommend, how quick would you recommend surgery over them trying to, I know a lot of doctors now are pushing towards physical therapy first over surgery. Would you advocate surgery first or physical therapy?
I definitely advocate for surgery as our last resort. For most elective things that I see in the practice, patients that come in that don't have a fracture or a dislocation or a tendon injury that the research would show, hey, if we don't treat this surgically, your long-term outcomes may be affected. But most of the stuff, thankfully, that I see in my elective practice, people come in and we try non-operative treatment first, almost unanimously. Even if a patient comes in and says, hey, my friend down the street just told me that they had carpal tunnel surgery and it was the best. They were doing so
Yeah.
well 5 days after surgery. We'll say, okay, well, let's back up. Let's make sure, number one, you have carpal tunnel, and number two, let's talk about the things we can do before surgery. And maybe you don't need it. I give tons of talks with our hand therapists here locally in Dallas, and I talk to them about how influential their intervention is in the story of my patients. I rely so heavily non-operatively and post-operatively on my therapists for the success of my patients. And as we alluded to, I'll see the patient for their surgical encounter maybe 2 weeks post-op, 4 weeks after that, maybe 6 weeks after that. But in that time where I've only seen them 3 or 4 times, our therapy team is seeing them a dozen or more.
Right.
And so that interaction to me is almost just as important as my interaction with them, and sometimes even more important. For instance, I just saw a patient recently that had a volar plate avulsion fracture and a deformity of the small finger, and I sent her right off to therapy. Those things, even though she had a trauma and a fracture and an injury, those things are treated better with therapy. So I do not shy away from non-operative treatment. And I even tell some patients who come in for second opinions or who come in and we're talking about the non-operative treatment. I'll even say, hey, if you go into somebody's office and they're pushing surgery and they're really not talking about non-operative treatment, you should be a little leery of that physician. Every physician should lay out every single option, even those options where surgery is going to lead to a better outcome. I always lead it off. I had a mentor at Ohio State that always would he would always phrase it first of all, we can do nothing, right? And I kind of phrase it like that in a sense that this isn't heart surgery, this isn't lung surgery, this isn't brain surgery. A lot of those surgeries, you need your brain, you need your heart, you need your lungs. Luckily, I'm fortunate where it's a hand, it's a wrist. It's important to me. It's what I love to do. But at the same time, you could live the rest of your life if a fracture doesn't heal perfectly, or it just affects quality of life and your ability to use your hand and wrist. And so when I talk to patients about non-operative treatment, I always say, hey, the first thing we could do is nothing. And that's a reasonable thing to discuss with a
Mm.
patient, but then outline everything. But the surgery would lead to X, Y, and Z benefits, and then have shared decision making, right? The physician that comes in and sees a patient and goes, yep, you've got knee arthritis, the only thing we can do is replace it. And the patient's like, oh, well, I don't really think I need surgery. It's like, all right, well, then get out of my office, come back when you're ready for surgery.
Right.
That is unfortunately a truth of our field. It happens quite, I don't want to say often, but it happens often enough where we see it. And I think that doesn't do a service to our patients to let them know all the options.
Yeah, well, I have seen a lot of my patients are going through this, what you just said right now. The surgeons only want to see the patients if they are going to say yes to their surgery. They don't even want to discuss the second option or anything that is beyond surgery. And my
Yeah.
parents are really, like, they were really pissed off. So then we got another doctors that we have one-on-one relation with, and we send them to them, and they started with corticosteroid injections and try relieving the pain. We did aggressive therapy according to MRIs, and we got to know, okay, there's a tear in the rotator cuff, so let's strengthen, let's stretch out this. But I have seen and I've come across doctors that just want to push for surgery, and that's so sad today. People
I agree 100%.
people have no knowledge. They're just scared, like you said. If you just sit down and talk to them for a few minutes, and you take that fear away, they will listen to what you have to say.
Absolutely. Yeah. And the other thing I try and do is I forget how old this study is, but I remember hearing it in training that patients during an encounter with a physician only retain about 30% of what you say. And so sometimes it's the good 30%. Sometimes it's the 30% that they just remember that I'm from Ohio and played
Right.
baseball and they remember nothing about their pathology. And so I try to provide as much education through the literature provided by the American Academy of Orthopedic Surgeons and the American Society for Surgery of the Hand. There's so much good patient information that will then hopefully steer a patient away from Dr. Google and all the scary stuff that they could find on the internet. Here's some good literature. I typically say, here's this packet. Once you get out of here, you're not going to remember something. And if this packet doesn't answer your information, call me.
Mm-hmm.
Leave a message with my MA. She will reach out to me and we'll answer your question for you. And the other thing I do, and I found this really, really beneficial, and it helps patients a lot too, is again, not heart, lung, brain surgery. Take the weekend, take a couple days, go home, talk with family, see if you have friends or family members that have gone through this before, see what their journey was like, and then call me back. You can come back in for another appointment. We could talk about it more. You can call in and say, hey, let's move forward with surgery. You can call in and say, hey, let's move forward with therapy. You don't have to make a decision in the room. And I feel like that helps patients a lot because in the room, patients kind of get a feeling sometimes of, like a car salesman. They're like, I don't want to say no because I don't want to disappoint my doctor. But it's like, hey, not making a decision is just as important as making a decision. Go home, think about it, come back. Here's the literature, read it, make sure you understand what's going on, and we go from there. And that has helped a patient anxiety a lot because as a physician now, we're only getting sometimes 10 minutes to see these patients, and 10 minutes is not a lot of time. It goes, I mean, we're already 23 minutes into this thing and it went by like that.
Yeah.
And so it's nice to be able to give patients the opportunity to decompress the information because a lot of times we're trying to fit a lot of information in 10 minutes and I talk really fast so I can fit a lot of information really, really quickly. And sometimes that's not good for a patient to make an educated decision.
But I like the fact that you're giving all of your information. Like you said, if they're taking away 30%, I'd rather have them take away more of 30% than what I'm giving them.
For sure.
So that's really awesome. What is your opinion on corticosteroid injections?
Great question. So corticosteroid injections are a good mainstay of non-operative treatment for me whether it's trigger finger, arthritis in the hand and wrist, carpal tunnel syndrome, rotator cuff pathology, intra-articular shoulder pathology. I think it is a good way to help manage discomfort while we're doing a treatment option. Some of these steroid injections can be curative. Trigger finger, there's good research out there that shows a couple of steroid injections can be curative for trigger finger. And again, surgery for me for these conditions is my last resort. So conditions like arthritis, some tendonitis, trigger finger, I'm really dequer veins, the first dorsal compartment, tenosynovitis. I'm really trying to use steroids for sometimes possible curative. And then I also use it sometimes as kind of a diagnostic therapeutic. Sometimes, again, talking about hand and upper extremity surgery, so complex, whether it's the shoulder, the elbow, or the hand or the wrist. And sometimes you're like, I may not have 100% idea what's going on. I may have like 3 ideas. And what you can do is you can do like a lidocaine steroid injection and see if a patient gets better. So for instance, I had a patient come in with a crush injury to the hand and forearm, went through non-operative therapy with a separate provider and then got referred to me. And, a couple of months after his crush injury, he's like, I'm still having a lot of pain. Sent him for a nerve test because I'm like, well, maybe your nerves got a little damaged. Nerve test, completely normal. Comes back and he's like, I gave him some other medicines to try. We're continuing non-operative treatment. He comes back and he's like, I don't get it. I don't know why I'm not better. And I'm like, let's do this. So threw an ultrasound on his carpal tunnel, found the nerve, put a little lidocaine and steroid right there. Came back in 10 minutes. How's your pain now? It's about 50% better.
Oh, wow.
I'm like, all right. So we're on the right track. What pain is better? What pain is not better? And then he's
Correct.
like, oh, you know what? it's kind of the top of my arm. It's really still bothering me, and I'm getting pain into the fingers. I'm like, okay. Threw the ultrasound on again, found the nerve in the radial tunnel, threw a little bit more lidocaine steroid there. 95% of his pain went away. And so not only can it be therapeutic, so like in
Right.
for this particular patient, he's feeling better, and maybe it's curative. Maybe throwing a little steroid on those nerves, calming those nerves down, maybe he won't need a surgery. But we're able to utilize a lidocaine steroid injection to help diagnose his condition and hone down like, hey, what is going on? You had this huge thing fall on your arm. You got all this space, pathology all over. Where can we localize it down to? And with a couple of injections, we were able to localize it to his radial and carpal tunnel.
Can we use that for referral pain too?
Yeah, absolutely. It's we have a good interventional anesthesia team in our practice, and they utilize trigger point injections, referred pain injections. Yeah, a lot of times I'm treating complex regional pain syndrome, and um, I'll have a patient go to one of my partners and get a sympathetic nerve block in the upper neck and take care of their pain and swelling in the hand. There's so much that can be done minimally invasively now in to treat discomfort and to treat pain. It's really impressive.
That's nice. I did not know all these facts because I see a lot of patients with back pain that have got the steroid injection, but it has not helped anyone. So I was
Yeah,
wondering because if it's helping maybe the smaller joints, is back is very complex, and I know how, um, and it's very big. The muscles are so big in the
yeah,
back. So could that be one of the reasons why different body parts have different effects to steroid?
absolutely. It could be severity of pathology. Sometimes a person's pathology is too severe for a steroid to work. Sometimes, and we see this a lot, and it's borne out in the research too, that as patients get more steroid injections for the same condition, it doesn't work as well with the subsequent injections. Maybe the first one gave you a year relief, maybe the second one 8 months, maybe the third one 7 months.
Yes.
And so we see that as well. And then honestly, there's some patients who, and they'll come in and they'll even tell you, like, I'm resistant to steroid injections. I've had injections for my knee, my shoulder, my hip, and whatever, and none of it works. And I'll take those patients' word for it because they know their body better than anyone. And if they've had steroid injections before, especially with people I trust, I'm like, hey, you know what? If you're not, and like we talked about, expectations and catastrophization can have an effect on a patient's outcome. So if a patient is like, I've had 6 injections all over my body and it's never worked, and I'm like, all right, well, let's still try one anyway. They're gonna roll their eyes and be like, all right, well, it's not gonna work. And if they're in that mindset, there's good research that shows that that affects a patient's outcomes.
Correct.
Um, and then also, I was talking to one of my partners just last week, and the hand especially is littered with such small areas to fit small needles. And I'll tell some patients that get referred to me from other providers, and they'll say, "Oh yeah, I've gotten a couple of thumb CMC injections, and I don't think they've ever worked." And that's a tough joint to inject. And so I'll tell a patient, I'll be like, "Hey, I believe you. I believe you have had a needle put somewhere over here, and somebody injected something there.
Right.
I don't know if they got in the joint." And so for me, and that's not to disparage a referring provider. It's more so that some stuff's really hard, and that hard stuff, some provider may just kind of, and it's an uncomfortable injection, and they'll just kind of poke around, and the patient will be in too much pain, and they're like, just let's stop or whatever. And they're like, all right, well, let's just put the medicine right here, and it's not even in the joint. And so I'll tell patients sometimes, like, hey, if I didn't do it, I don't consider it that it was done.
Right.
um just because I don't know. And so that, I think, factors a lot into, does an injection work in the spine? It's person dependent. Did the provider get it in the right spot? Is the pathology too significant for the steroid to work? I had back surgery myself in June. I herniated a disc in my back, and I had one of my partners inject my back, and in 3 days, 75 to 80% of my pain was gone.
Oh,
But I've also, in my training, seen exactly what you're talking about, where we'll do an injection and a patient will come back and say, I got no relief. Some people even come back and they're like, made it
Yeah.
worse.
Yeah.
And in your mind, you're like, well, shoot, how, what happened there? And it's like, well, the body's a crazy place, and injections are variable. I mean, sometimes it's a millimeter one way, 2 millimeters the other way, and you're not in the right spot.
Right. Could they, uh, I wouldn't say allergic to steroids, but could they be different way that the body's reacting to steroids?
Absolutely. There's good research that shows that patients can get flare-ups. You know, you're talking about how this steroid shot can provide you some relief, and patients 3 or 4 days after their injection, they're in more pain.
Yeah.
And that's I don't want to call that, like you said, it's probably not an allergic reaction, but probably more like an adverse reaction to a steroid injection. But then I've seen patients, you know, like we were talking about, they just through experience, they're like, I'm resistant. Steroid shots don't really work for me. And there are different steroid shots. There's Kenalog, there's dexamethasone, there's betamethasone. And so, I mean, maybe it's the type of steroid. You know, as we're learning more and more about people's DNA, like with degenerative conditions, you know, the analogy I like to use for my patients when we talk about arthritis, like, I don't know where this arthritis came from. I've worked at a desk my whole life. Like, I don't do anything. It's like, well, take, you know, offensive linemen. Let's say you take a group of 20 offensive linemen. They all had 10-year careers in the NFL. How come not all of them get hip and knee replacements, right? They all lumbered down the football field for the same amount of time. Some of them got it and some of them didn't. We're learning more and more about DNA and genetics, not necessarily hereditary, because patients will come in and be like, "Well, my mom and dad never had arthritis. How come I've got it?" Well, you told me it was hereditary, and I'm like, "Oh, well, let's back up. It's genetics. Yes, you got your genes from your parents, but the way those genes came together in your DNA can either leave you predisposed to some degenerative conditions or it can be protective." And so, as we're learning more and more about DNA, and again with preventative medicine, we're hopefully going to start being able to screen some patients and say, "Hey, man, you're at high risk for carpal tunnel," or "Hey, you're at high risk for arthritic conditions." I mean, you see patients, I'm sure, that come through the physical therapy office. They're like, "Yeah, I've got both shoulders done, got left hip, right knee. I'm talking to my doctor about getting my big toe replaced." And it's like, well, goodness, what did you do your whole life? And it's like, I'm an accountant. And you're like, what
Yeah.
in the world? Like, what kind of accounting do you do? That you're the bionic man or the bionic woman? And it's just there's just a genetic predisposition to these things.
What are the most common injuries you come across?
So injuries, traumatic injuries, fractures in the hand and in the fingers, metacarpal and phalangeal fractures, broken wrists. I think
Mm.
the last research I saw was that distal radius fractures are, I think, the second or third most common fracture in our elderly population. So I see a lot of distal radius fractures. I do have a love for the elbow, so I've become kind of the elbow person in my little area, especially for my partners. And so I think elbow fractures, radial head fractures are very common. We do have a very robust high school sports community in this area. Our practice alone, I think, takes care of 12 or 13 high schools. And so we see a lot of adolescent overuse injuries, tendinopathies, ruptured tendons, fractures, see a lot of sports injuries. I think second only to the elbow is the shoulder. I love shoulder pathology. So doing shoulder replacements, whether it's for fracture or for arthritis or for arthropathy, rotator cuff repairs, those are probably, and then those are probably the most injuries I see. But my particular interest is with nerve surgery in the upper extremity. I was very blessed and fortunate to have worked with some pioneers in peripheral nerve surgery at Ohio State and at Ortho Carolina through my training. And the community here north of Dallas Fort Worth really doesn't have a robust peripheral nerve surgical presence. And so in my short time here, I've tried really hard to make myself just known to the community as a resource. You know, you don't have to go downtown Dallas or downtown Fort Worth. We're doing those surgeries that normally you'd go to an academic medical center. We're doing them right here in your community, whether it be upper or lower extremity nerve surgery. That's kind of been a very distinct passion of mine, and it's done really well so far. Just in the short time I've been here, I've been fairly successful.
That's really nice. Congratulations. I can see so much happening for you, and
Thank
you're
you.
really interested and you're really passionate about that. So that reflects. Just by talking to you, I can see, I can go
I
on
appreciate
and
that.
on.
I
But
feel like some people are like, when you get older, you'll lose it. And I'm like, I hope not. I mean, I really took a lot of time trying to figure out exactly what I loved doing. And I had really great mentorship along the way that fostered that passion and that enthusiasm. And again, I think if I can bring that enthusiasm to my patients, it shows in them too. They'll come back and they'll just be like, you're just so excited all the
right,
time. And I'm like, yeah, I mean, I'm excited to do what I do. Even when you get those low lows and you have some complications or some bad outcomes, it's still a field that I've dedicated my very young career to. And I wouldn't, people ask all the time, what would you do if you weren't doing medicine? And honestly, I have no idea. Um, some people think I should be a stand-up comedian. I don't think, I don't
really.
know about that. But I find myself loving what I do every day and the people that I do it with.
So there are some rumors and some jokes that are hidden. You have to give us something.
Oh my gosh, no, I got that is it's been something that I've been told a lot is I am very I think I'm very funny, but it's mostly interaction. Like it'll be in a conversation. I can't. My roommate from college, he's done some stand-up comedy, and he does better to like write jokes and do jokes, and I think that I'm just more like real life funny.
Yeah, just like naturally it comes to you.
Yeah,
Yeah.
exactly. It would I haven't been successful in trying to be funny. I just kind of I am. I don't know.
That was funny.
Thank you. See, exactly. That's what I'm talking about. That's what I'm talking about.
You like yeah, you mentioned that you don't want to lose it. I can see it only grows. The only thing is how much we can pass it on to our next coming up generations, people who are following us, people who are just observing you. So that's what is more important. And like you said, you love teaching. Can you tell us more about how much you love teaching, what you love teaching?
Absolutely. I was fortunate enough to be our chief resident with my colleague who does trauma surgery up in Minnesota, and uh, that I knew I had a passion for teaching very early on. I thought that I had a unique ability to um, convey education not just through words but through demonstration. And so as I became the chief resident with my colleague, um and you kind of are imbued with like, hey, you're the chief resident, like your one of your major responsibilities is to teach. I had an email from one of my really good friends and junior residents about our impact and how important and how influential that was to him during his time, and knew that once I got out, whether it went back once I got out of training and whether I went into academics and was a formal educator, or I went into private practice, which is what I ended up doing, I needed to be able to continue to teach. I have so much fun teaching about something I love. And so now, even though I'm in private practice, I've done some teaching to orthopedic implant representatives, teaching them about techniques. I mean, even when I'm doing a lab and I'm learning, I'll schedule a lab with some of our orthopedic colleagues, and they'll be around and I'll just want to teach. I'll just be like, oh, look at this. This is really cool. Or hey, have you ever seen this before? And one of my reps is very young, and most of the time she says no. And so I'm like, all right, cool, get over here. Like let's look at this. This is really cool. Because I find that it's so much fun to teach and relay, like you said, to that next generation. Eventually that rep is going to be a senior rep and she's going to have to teach her junior reps. And I hope that if I was able to provide a good learning experience for them, that they'll then be an advocate for that next generation. And I've gravitated now towards social media since I don't have residents or anything or medical students with me. I've tried to do some education through social media. I think social media for orthopedics is in its infancy in its ability to educate medical students, residents, colleagues, and eventually patients. We're seeing it now in the field of plastic surgery. I mean, they are championing the medium of social media, not just for marketing, but for education. And I think that orthopedics can be that as well. And that's one of my kind of side passions outside of my practice is how does an orthopedic surgeon successfully educate colleagues, residents, fellows, and it's a medium that I think is just starting to be utilized more and more, and I'm excited to see where that goes as far as teaching is concerned.
You took over my next question. What do you think about telehealth, and is it the next step in healthcare?
So telehealth, I have found, as you know, Dallas Fort Worth is far away from neighboring near metropolitan areas, and so we do get a lot of referrals from the kind of North Texas country, and it helps accessibility. I think telehealth has been a way to see a patient and follow them longitudinally without inconveniencing them. The last thing you want is a patient to be isolated because the drive is too far or they feel like they can't make the post-operative appointments. Normally I see a patient 2 weeks, 4 weeks, maybe 6 weeks, 8 weeks, 12 weeks. That's a lot of driving, especially for, someone who's coming from the country who doesn't really come to the city a lot. It can be intimidating. And so I think that has made care, not just through orthopedics, but I think primary care especially, I'm sure they've just exploded with their ability to access patients just through telehealth and it be effective. Um, Social media has been an interesting way for me to not just continue my passion for teaching, but I think the next, and I've even seen it in this generation. I thought it was going to be something that I was going to see 10 years from now, and I was just kind of trying to get a foundation for what that would be. But I've got patients who are on Medicare. They're grandmas and grandpas, some of them great grandmas and great grandpas, and they're like, "Yeah, I found you on Google. I read your reviews, and like three things down was your Instagram, and I saw some of your videos." And you're like, "Oh, I didn't know you knew how to use Instagram."
Yeah.
But it's becoming, like I said, much more applicable earlier, and I think with how specifically orthopedic and upper extremity fellowships are starting to harness that ability to recruit fellows with the pandemic. Everything became digital, and I was like, all right, well, how do I know that this program that I'm interviewing at is any good? And so being able to use social media, but then that has transferred into marketing. Ohio State, where I trained, they do a wonderful job on social media with their therapists, their associate providers. They have cases that they do. They show the outreach that they do in the community, and it's just that is like the perfect way to introduce your practice and the things you're passionate about and what your group is about to the community. And this will just become an even larger medium as we get older.
The social media in general, not health, but social media in general is just picking up. Like once it's viral, it's out there, people can grab it. So easy, it's so accessible.
Yeah.
I really think telehealth is the next step towards future, towards health. And yeah, like grandmas are using it. So
Yeah, I mean and this is no slight to Nana or anything, but
yeah,
I didn't think it was going to be this influential this early in my practice based on the generations that grew up with technology are just starting to get kind of into the age group that we see. Orthopedics is typically a as we age wear and tear sort of subspecialty. But it's already been such a positive for my patients. I think that they're able to see outcomes just like our plastic surgery colleagues, a lot of before and after videos and pictures. So patients can really see, like, hey, this guy or gal knows what he or she is doing. Look at the results. They're right here on Instagram. And so that is a visual medium. A lot of elective cosmetic plastic surgery, you can see the difference and
Mm-hmm.
understand the difference. And orthopedics, we need to do a little bit of education. It's like, well, that I don't know what I'm looking at. Is that X-ray broken? Is that bad? I don't know. I just saw a patient today who he was referred from an emergency department, and I asked, did they go over your X-rays with you? And he was like, yeah, but I don't know what I'm looking at. And so when you show those sorts of X-rays on social media, patients or potential patients or anybody viewing your video without kind of a medical background, they're going to look at it and go, I don't know what that is. And then they're going to look at the after picture and be like, I don't know, is that better? What is that? And so being able to tie in the education to the orthopedic audience, I think that plus patient testimonials, kind of talking about what were they going through beforehand, showing an image, an X-ray, an MRI, and then the patient testimonial after is how orthopedics is going to continue to utilize social media as, I don't want to call it a marketing tool, but as an education tool for patients who are looking for providers. Oh wow, this is shoulder arthritis, and I'm looking at this just like people are looking for Botox injections with cosmetic plastic surgeons, and they're going to look at shoulder arthritis now the way they do before and after pictures from Botox, and that I think is the goal.
How do you think, how would you like to approach social media with as an education platform, personally
Yeah,
speaking?
I think I work actually with the AAHS, which is one of our hand societies, and I'm part of our social media task force. And so we have meetings and interactions through email and through our meetings in person, where we talk about, like, what are we going to do? What do we want to do with education? And I think the options are vast. And I think for me, utilizing what is popular for non-orthopedic or medical social media
Right.
and tying that in. So I do a lot of reels. I do a lot of kind of stories on Instagram with some music to it, to try and tie in sort of what social media is outside of medicine, and then merge the two together. And I think that's a good way to obtain a following, and then from there you can start to do, I don't want to call it the boring stuff, but I had a conversation with an orthopedic hardware company. I'm like, it's got to be, our attention spans with social media is so quick.
Yeah.
And so doing a post with this long prose afterward, nobody's gonna look at it. It's like too many words.
The-
Scroll, go, next one. And so being able to tie in education in a brief spot. I think there's a couple of people who do a good job of kind of interesting things, like things that are weird, like, shark bites and stingray harpoons and stuff like that. Like, that's cool. Like, oh, like a cool bloody stingray harpoon in the arm. Like, let's watch this guy's 30-second talk on that. But for education, for residents and fellows, just being able to get that little snippet for about 30 to 60 seconds and figuring out how to maximize that time is where my kind of passion is going. Where how can I do that? How can I accomplish, again, like with a patient encounter, how can I accomplish the most um, effectively and efficiently in a brief period of time?
I think, what do you call it? Stand-up comedy would be amazing.
Yeah.
You should try.
Do like stand up comedy medical education version? That'd be pretty cool.
Yeah, but I remember talking about the short reels and interesting, funny ones. I remember how I learned dermatome and myotome was through the dance, the dermatome myotome dance. I don't know if you've seen it.
I haven't yet. I haven't.
It's so interesting and it's so quick. And if
Yeah.
you come from a dance background, or even if you like to see something that's moving,
Yeah. Yeah.
just the dermatome, myotome, it's just quick, easy, and someone is dancing in front of you, plus educating you at the same time
Yeah.
about the nerves, all the way from cervical to lumbar.
Yeah.
So I was very interested, and I like but it's so difficult to make such videos. requires such talent to get that information and just put it in a small 30-second, 60-second
For
video.
sure. For sure. I know I didn't utilize this in medical school, but I know how influential it is now, these short little YouTube videos for the kidney or whatever. And it's some clever little story to help the medical student just memorize like how the glomerulus works or how the absorption in the gut works in the small intestine. It's just this like little, like you said, like a little 1 minute video, but they're so creative.
Yeah.
But there's so much information in medical school that like if you can pack it down into 1 minute just to remember a big topic, I mean that's super effective for a student to be able to take the exam and absorb the material. And so I had a couple of close friends that were behind me in medical school where that was really starting to become popular, and I think it's only gotten even almost I dare say it essential to a medical student's education to do those kind of little quick either mnemonics or videos from YouTube to remember these sometimes complicated topics.
All right. What is next on your agenda? What are the next projects that you got in hand?
So this we call this kind of deductible season. So this next 2 months for us orthopedic surgeons is always very, very, very busy. Everybody's met their deductible from the past 10 months, and they're coming in. They're like, I'm getting the tires rotated, the filters checked, the fluids rebalanced, all this. So everybody's coming in wanting surgery pretty quick. So I think the next step for me professionally is to keep my head above water the next 2 months. Just get to January 1st as quickly and as safely as I can. My wife and I have a newborn. He's 3 months old on Friday, so trying to balance a growing family and a practice through the holiday season is also going to be my next big personal task.
Yeah.
I've got a lot, I think, moving into 2024 with social media, with working with some industry on that, working with some industry on some educational forums and lectures. I'm communicating. I actually have been putting off this email far too long, so I think when we get off, I got to answer this email. They're going to be pretty upset. It's a course that we're trying to get together for next October's Hand Society meeting to talk about social media. And so we're really, I think, getting into the early stages of trying to plan that. Um, I think that's it. I think, I mean,
That's a lot.
to me, it was like, oh man, you only listed 4 things, but I'm like, those are really time consuming. Like, I'm probably gonna be very busy with just those 4 things.
But congratulations on your newborn baby.
Thank you, thank you. He's a healthy, chubby little man. So we've been blessed with a healthy baby boy, and his big sister loves him very much, which is much appreciated. You know, you never know what you're gonna get with a 3-year-old, and so she likes him more than we thought she would,
Yeah.
which is great.
Well, I'm a big sister, and I have a younger one who's 3 years younger to me. So
Yep.
it takes time. We're not used to sharing, but once we love them, we're the most protective creatures on earth.
That's what we're hoping for. My wife is a big sister too, and so she says the same thing. She says the same thing.
Yeah, there'll be fights, a lot of them growing up. So be prepared. But other than that, we like right now also I will give anything to keep him safe and just to keep him happy.
Of course, of course.
Well, congratulations, and I love that you have so many things planned out for you, and you're gonna be super, super busy. I love that you're not just stuck to just work and just surgeries. You're trying so many new things with social media, with lecture series, so many things and so many projects. That's so exciting, and I love that for you.
I'm while I've got the youthful energy, I've gotta use it to do good. I've always been my mom will even attest to this. I always do and commit myself to way more than I probably should, but I don't think I would know what to do with myself if I didn't. I think that it keeps me motivated to kind of keep so many plates spinning at the same time. And again, I love doing it. If I didn't love doing it, I don't think I'd do it. And I think the reason I keep doing it is because I really do enjoy as many things as I do, and that includes taking care of my patients and being a good surgeon.
You know, you we serve a fist. I'm exactly like that. Go for it. Go for it. I will overdo it, and my mother will be. She just commented. She's like, "Why do you have to stress yourself so much?" I'm like, "Ma, because I love it,
Yeah,
and I'm so passionate about it, so I will do it." And she knows that. So we're the same. I cannot sleep if I am not satisfied with what work I'm doing. And it has to not only be productive for me, it has to be productive for the society, for
absolutely.
um, people who are looking up to us, and we don't even know that they look up to us. Like, I look up to you so much, and I love the work that you're doing. It's going to be awesome. I'm so excited.
I
It's gonna,
appreciate that. Thank you. And you too. You too. In just the brief time I've been following you and your talk about health lecture series, it's been educational for me, and I was excited to be a part of
Thank
it.
you so much. What would be one thing that you would tell 18-year-old Steven to
Oh
do?
boy. Oh, if I could get his attention, he was a wild man. I mean, oh my goodness, 18-year-old me. Okay. Um, After he puts down the gaming controller, I would tell him that it's worth it. Um, I I was a very unique 18-year-old. I lost my dad when I was 15, and I lived by myself from the age of from being a junior and senior in high school. I was in my own apartment, living by myself, trying to finish high school. Um, and those early years for young me were tough, and there were often times where when I was that young, knowing I had aspirations of something greater, where it would have been easy to um, give up, to just be like, you know what, I'm not gonna. That's just too hard. And even doing what, getting to the point where I am today, like there were plenty of times where it would have been easy just to be like, you know what, this is too hard. And so I think if I could go back, I would tell myself that it is truly all worth it. Um, I love what I do so much. I'm so fortunate that I'm able to help people who need help. I'm so blessed with the ability to be able to teach and be a good role model for our younger generation, and I've got a wonderful family that supports all that. And I wouldn't be where I am or who I am without them either. You're gonna make me cry. I'm gonna make me cry. Um, and
Sorry,
it's I yeah. So I would I would tell young me that it's worth it. And I have a lot of employees in our practice that they're all in the age group right now. They're trying to do that next great thing, and um, I try and keep them motivated, just like I would tell my younger self to stay motivated and that it's all worth it.
okay. I'm not crying. I
I
got
got close. I
cry.
got I got close twice.
No, no one talks about those things. That's why I just yesterday I was thinking about it. No one talks about the journey. Everyone wants to see the destination, and only you and your closed ones know about what journey you have been through, and the rest of the world actually get to see the destiny, because they don't know the ups and the downs and the worst and the lows that you have seen, and you try to quit every single day. You try to just pull yourself down, but that's not what you're meant to be. That's not where you're meant to be. So
Yeah. It's and I tell the younger folks in our practice all the time, and I try and remember this as much as I can, and it's not easy, is that you never know what somebody's going through, right? Like you just said, it's unless you ask or unless you know, it's you never really know what somebody's going through. And so, patients come in and they're upset or disgruntled or anything like that. I try and remember the times where no one knew what I was going through, and how helpful it can be, to keep that in mind when you not just interact with patients, but with other people. Like, you never know what somebody's going through. And so, that me going through that personally, from a young age, um, again, definitely not perfect, but try to remember that, every day, whether it's with patients or people I'm interacting with, in the operating rooms or in clinic.
What kept you going?
Oh boy. Um, oh man. Okay, I can't cry when I say this. I wanted I wanted my dad to be proud of me, um, because I knew that I'd never know, because he was gone, and I would never be able to hear him tell me that again. And so I knew that, whether it was with being a doctor or being a dad, um, that's what kept me going.
He would love this. You. He,
So I do. It's been, shoot, almost 20 years, he's been gone, and it's
yeah.
still something that's very important to me.
That's all love. It should still be heard because you love the person. He'd be very, very proud.
I appreciate that. I hope so too.
Yeah, and he's keeping an eye on both the little ones.
Oh yeah, we talk about Grandpa Rich all the time. And even when they don't know, all the things that I do, that my dad did for me, I know how much it meant to me, when he was there, and they know him through the things that I do, that I learned from him. And so, yeah.
You are legacy. Live in a cat.
I don't know about that. I think um, I just do my best. I think that's all we can ask of ourselves is, is just, and not every day's a win. Not, I don't do my best every day. But I don't know about legacy, but I think I do my best.
That's perfect. That's all you can do. Like
Yeah,
in an imperfect world, that's all you can do.
absolutely.
Yeah. Uh, I forgot.
That's my fault. You asked a tough question, and when I have I don't know, I don't want to say a bad habit. I answer. I used to be. I was told this a lot when I was interviewing, is that, uh, you don't always have to answer quickly. And I was like, okay, that's good advice. It is good advice. I talk quickly, and I like to talk, and I typically will answer pretty quickly. But then when you ask what kept you going, I only had one answer. And,
Yeah.
uh, I apologize for that, derailing the interview.
No, no, no. It deserves all the derailing and all the attention because it's something that's close to you. And let's talk about health. Is I want to create a platform that's not just professional, it's personal too. It's a community for a reason because we can connect on so many levels that we would not typically do. And I started with so many of my professors and seniors that I knew for years, and I'm
Sure.
personally connected to them. I didn't just want to like research. You can still pull it from the internet, you can still read it, but it's so different and it's so impactful when you're listening it from someone you care about, from someone who really inspires you. And
Yeah.
everyone has a story. Like today, I feel your story needs to be heard, needs to be told. It's so inspiring, and there's a reason why another person will get up the next day and try to work just because he wants his father to be proud of him. So I love that. Thank you for sharing that piece and that story. It's really so important. Thank so much.
I appreciate that. I appreciate that. Thank you.
Okay, I had this question.
Okay.
What would you be if you were not an orthopedic surgeon?
Yeah, well, I alluded to that before, and
Yeah,
it's a hard it's a hard question to answer.
baseball player maybe.
I think so. So when I was in college and I was still playing baseball, I was like, maybe there's still a chance. And then once you get to that level and everybody is that good, and only a small percentage make it even past college, I was like, all right, like I'm 5'8". There's like no way I'm ever gonna be a professional baseball player. And then with the arm stuff, I mean, it was not in the cards for me. I would love it, but I don't think. Um, I've again I love talking and I love sports. So I'd probably do something sports related, whether everybody's got a podcast nowadays. It used to be like 10 years ago, if you had a podcast, it was like you and four other guys and you were so unique, your podcast. And now it's like anybody with a microphone and an iPhone has a podcast now. Um, but I'd probably do something where I could talk about sports, because that's something I do enjoy talking about. Um, I wouldn't. I'd probably say that. I like golfing a lot, but I'm terrible at it, so I don't think I can make a profession out of that. Um, or maybe I'd take the advice I keep getting. Maybe I would do stand-up comedy. Maybe I'd just figure out how to do
I
it.
can see that.
And just eat ramen for a while and save money and just figure out how to do that. I don't know.
I, I can see you have the face for it. You have the talent for it.
I appreciate that. I did some stage acting in high school in the off seasons of the sports I played, and I enjoyed doing it. But then, once you choose medicine, I mean,
Yeah.
that's it. You have time to wake up, breathe, and eat and do medicine.
No social life.
No.
But I guess these sports, if I were not a physical therapist, I would also to do something with dancing or sports for sure.
Yeah.
That's why I love outpatient physical therapy and on sports physical therapy. It's really exciting to me.
Yeah.
Yeah.
Yeah. And uh, it's everywhere. I mean, sports is like, the great unifier. I mean, whether it's, I mean, you don't have to like the same sport, but most people like some kind of sport. And so I think that's what's cool about sports, is it's something that unifies us even in rivalry. Like my one of my best friends, I'm a Cincinnati Bengals fan. I grew up in Cincinnati. His family's from Baltimore. He's a Baltimore Ravens fan, but we're best friends. And we, as much as we hate each other's teams, the love for the sport, unites us on Sundays, sometimes Mondays, sometimes Thursdays.
Anytime you get a good beer.
Yeah, that's right.
I miss Texas beer.
Uh,
You don't,
Texas has been great for a lot of things, including that.
yeah. I'll surely drop by. I have a lot of friends there in Texas. I really miss Texas. You're getting me nostalgic now.
Yeah, I'll tell you, people from Texas love Texas. I talk about, the patients that I see are either patients that moved here and never moved away, or patients that grew up here and are like, this is great. Why would I ever leave? Um, It's so and it's very few outside of that. Very few people who are just like, yeah, I'm here and it's meh. Like, people moved here and they love it, or people grew up here and they still love it and they stay. And there's very little moving between cities too. Like, it's very rare that I'll find somebody in Dallas who's like, yeah, I grew up in Austin and moved to Dallas. I like it better. Most people who grow up in Austin and do something in Dallas find their way back to Austin, and Houston, same way. It's not common that you see somebody kind of relocate cities in Texas. They're very passionate about their hometowns and their home cities.
I can see why. It was a hard time for me to leave, but I got a good job here, so it was my option. Like, I had no other, but I am definitely considering after a few years to just move back. And
Yeah.
Texas is amazing for physical therapy, good opportunities, good friends, good people, kind people. So
Yes, absolutely. I agree.
no No taxes.
That's been pretty nice too. That it's nice to see the larger number in the bank account sometimes. That's for sure.
It's so hard to have to work so much and then you pay the rent and the taxes and that's it.
Right. Yeah. My family in Connecticut will agree with that too. They're the
Oh,
Northeast, man, so many taxes.
what are a few sports injuries that you come across? Just with shoulder.
Oh, sure. Just with shoulder.
Mm.
Um, AC joint separations. See that a lot of clavicle fractures, especially during football season. Athletes where they're getting tackled on the side of their shoulder. You know, you get the AC separation or the clavicle fracture. I see a lot, and this is something that, you know, I emphasize with my patients when I see them because it wasn't something that was emphasized when I was going through baseball. Is shoulder impingement or the lack of appropriate pre-exercise or pre-sport stretching. So I'll see patients, especially at the beginning of throwing seasons, the beginning of baseball, and then the beginning of volleyball. That's another, you know, overhead velocity sport where they'll just get vague shoulder pain. And it's like, okay, you know, what's going on? You get the timeline and you do the internal rotation test, and these guys and gals have zero internal rotation and they're getting, you know, internal impingement. And so I see, especially with, like I said, how robust the high school athlete community is that we take care of in this part of the DFW area. I see it a lot. So thankfully, the traumatic injuries in the shoulder are few and far between for our young athletes, but there's definitely some deconditioning and some mechanics injuries that we see, or that for me that I see a lot of.
Yeah, we were talking about sports and I was like, I want to ask, what injuries do you come across so common?
Yeah, those are probably my biggest sports ones. Pickleball has taken this area by storm, and so um, if I were had more foresight, I would have put my stack of business cards on the front of this little pickleball place down the road here because I think I see, geez Louise, 2 to 3 injuries, whether it's fractures or sprains or something with pickleball. It's like when the bird scooters first came out and everybody was breaking bones coming off of those bird scooters going 15 miles an hour
Right.
after the bars in Columbus. I mean, that alone probably put my trauma mentor, her kids through college, just seeing all those fractures off of those bird scooters. So the pickleball court is now the bird scooter. So I see tons of fractures from that, tons of injuries, and so do my partners, not just upper extremity. I mean, we're seeing Achilles tendon tears, we're seeing old people with meniscus tears related to pickleball and stuff like that.
Right. Do you have any students or mentors, any students that you're mentoring?
So I was recently very fortunate enough to hire a physician's assistant, and she is graduating this winter. And so she's been shadowing me a little bit in my office, and so that's been really cool to have somebody. Physician's assistants don't get a ton of orthopedic exposure, and so from what I've been told, when they find that that is where they'd like to work is in the field of orthopedics. They try and get as much experience as possible, but they don't get a lot of knowledge before that. And so it's been really fun to have her in the clinic the last couple of weeks and teach her some cool stuff, some cool techniques. When I first came out of fellowship, and I knew I wasn't going to be, you know, a teacher of residents or fellows, or at least now. It was a bummer, and most of it was because, like, when you do something cool in surgery or you make a cool diagnosis, like, you just want to turn to somebody and like high five or chest bump or something. Like, this is so cool! Like, look what we just did. And one of the first surgeries I did out of fellowship was this lovely woman. She hugs me every time she comes in. That was my first surgeries. She had a total elbow replacement 5 or something years ago before this surgery, and her elbow replacement had wiggled loose in her ulna, and it had wasted away the bone. The bone in the ulna was no longer usable. And so I put an allograft ulna and I telescoped the new total elbow into this dead person's ulna and then put that into her for her new total elbow. And it took a long time. And you're looking around and you're just like, this was so cool. Like, look at what we just did. And people are like, can you close? Like, we gotta go home. We got shit to do, and I don't want to die. I'm not high-fiving you. And I'm like, oh man, like this is really exciting. I guess I'll just close now. And so it'll be fun, I think, to finally have like somebody to high five and chest bump. I will say I have a surgery center, and my staff at my surgery center is awesome,
Yeah.
and they will high five and fist bump me if I'm on time. If I'm late, no high fives, no fist bumps. I got to be on time to get fist bump. But they're awesome. I think my staff at my surgery center is thankfully just as enthusiastic as I am. They're a delight to work with. So that's when I first came out, it was disappointing, and then I made friends with my staff, and now that I've got my PA starting, I'm sure there'll be more high fives and fist bumps.
Yeah. Do you also work with the trauma team at the hospital, or just practice?
Yeah, so I take level 2 hand call at one of the trauma centers down the road, and I work very closely with, and so do the rest of my practice, not just me. When they have stuff that's a little bit not straightforward and needs kind of a subspecialty expertise, they'll call me, and we're always exchanging patients and things like that. I think that was one of the other things that I was worried about is, in a community of predominantly private practices and hospital systems as opposed to academics, there wasn't going to be as good a collegiality. And I just had a friend, a colleague from a local practice recently call me in the middle of surgery, and he was like, hey, can I ask you a question? And so that has been a great surprise, was that even though on paper we work for different companies, we're more collegial than I would have anticipated, and so that's been great to be able to have that community of where we work so closely together.
Right. I think I'm gonna direct my ortho question to you next time.
Happy to.
A lot of like I think I do well with lower legs because I like sports. I have done a lot of sports. So as soon as hip, knee, ankle, I'm your guru. Like I will get you running within 2 months, 3 months.
Yeah,
I got you. But when it comes to shoulder, I'm a little hesitant. But
sure.
I have had amazing results, amazing feedback from patients. But again, it's like I can do better. There's scope for me to do better. So I think I'm gonna be bothering you a lot now.
Please do. You know where to find me.
Definitely. Well, our other viewers don't know where to find you. Can you tell us about if they want to if they have any questions, where they can reach you out?
Sure, sure. So I am just north of the Dallas-Fort Worth area in a small, well, I don't say small, in a okay sized town called Grapevine. It's right where the DFW airport is. And my practice is there in Grapevine and just a little bit west in an adjacent community north of Fort Worth. I have my social media handles here, so if you have any questions, like, subscribe, interact. I'm always happy to talk in the comments and discuss orthopedic surgery or medical education or how to navigate the job market. I think that's something I did not anticipate needing the education on when I was looking for a job. And so I know a lot of young, aspiring orthopedic and hand surgeons are going through what I went through, which was like, what is a contract? What am I looking for? Why is a guarantee important? Why is a moving bonus important? What is private equity? I mean, that's all these things that are starting to become something that you have to pay attention more to now than maybe you did 25, 30 years ago. Um, yeah, I'm happy to interact on social media. If you are someone in the community watching, we have a website. It's a link in my profile. You can schedule an appointment online and see me anytime. Yeah.
That's awesome. Thank you
Or
so
or you'll
much.
find me on the golf course. I've gotten so many people that like we'll just be sitting there and we'll just be like, oh, and what do you do? And I'm like, oh, I'm a hand surgeon. And then all of a sudden I'm doing level 5 appointments on the golf course, checking ACLs and rotator cuffs in a golf cart.
I love that. That's what happens to me in subway, in trains, and if someone sees me in scrubs, because I'll have my scrubs on sometimes, and they'll be like, "Oh, are you a therapist?" And then they're like, "Oh, I have a lot of back pain. Can you recommend some exercise?"
Yep. Yep.
Yeah, in a subway. That's exactly very right.
Right,
Exercises.
right. It's like, oh well, that homeless guy's sleeping over there, but sure, sure. I'll just lay down here on the subway floor and I'll show you some Mackenzie bend exercises.
The cat cameras, just yeah.
Yeah.
Well, thank you so much, Stephen. It was lovely talking to you and knowing your story. Just lovely how passionate you are towards orthopedics and surgery. It was amazing talking to you. And thank you so much for giving me your time today and for sharing your story with us.
You're very, very welcome, and thank you for the opportunity. Love doing stuff like this. So hopefully it was great for you and for your
It
followers.
was lovely. Thank
Awesome.
you. Have a good night.
Thank you. You too. Good night.
Bye. Thank you for listening to our talk about health. You can follow me on Instagram at bhavna.devnani, on Facebook at bhavna devnani, and we'll leave all the information in the description below. Thank you.